It is connecting.
Yeah, it says it's live. All right.
Good evening, colleagues, ladies and gentlemen. A very warm welcome to all of you to the yet another session of the current season of IPC Masterclass 4, which is named COVID-19 Learning from Past Waves in order to prepare for the next. Last 4 weeks had been a great time with Professor GVS Murthy, Dr. Anup, Dr. Aruna, Dr. Sukanya, taking us through the entire spectrum of different functions and also different categories of activities which we need to do during a pandemic. Professor Murthy talked about more from the public health and epidemiological perspective. Dr. Anup has talked about the management protocols, Dr. Aruna about the secondary infections, and Dr. Sukanya about the vaccine and vaccination program, both nationally and internationally, which has given us the broad picture on what is happening around us in terms of the first wave and also the ongoing second wave. What are the distinctive uh, kind of differences which we all have faced, and how did we face them? What were the conclusions? And since it has been all hit and miss, and also learning on the way, so we have also learned from the experts what they have done, where did they go wrong, and where did they go right, and from that right, what are the lessons we can take forward in order to make our institutions, our countries, our globe safer for the next wave or the future public health emergencies. So going ahead, probably, since we already talked about the first two waves and also, the impending third wave, etc., etc., I thought I will take this opportunity, which is given to open today's discussion forum, where the distinguished panelists are going to talk about various aspects which were not covered in the first four sessions. I thought, I will share a few distinct kind of measures and also, the kind of actions which are required to mitigate the future threats of pandemics and public health emergencies. As we all know, that only certainty going ahead is that we shall have another public health emergency of international concern sooner than what probably we are assuming, sitting today tight in our countries, our homes, our hospitals, etc., etc. Only the thing what we don't know is when and what scale of destruction the next public health emergency may cause. That is the only thing which is not certain. But otherwise, it is more than certain that we will have the public health emergency emerging sooner than later. The future pandemics, when we talk about them, are likely to emerge from ecological processes, that is climate change, loss of biodiversity, or it may be from anthropogenic social processes, that is the corporate interests, culture, globalization, mining, and all these things. And of course, we cannot actually forget about the world population growth, which is happening at a rate which is unimaginable today. It is evident that we shall have these public health emergencies with increased frequency and higher devastating capacity. And hence, intervention would therefore require modifications or dampening these generators and prevent future periodic pandemics that would reverse human development. So as we talked about, the multiple angles which are related to the future pandemics or the public health emergencies. We need to deal with them with a very broad approach to the problem. Although this current series is named as COVID 19 and its waves, if we are going to focus predominantly on COVID or COVID in isolation, we may again land up in a very narrow conjecture in terms of our preparedness for the future, for the plans for the future, etc., etc. As you probably are aware that in 2018 itself, World Health Organization has released managing pandemics, the kind of roadmap which is required in order to manage them, and it also has actually given key facts about the deadly diseases, and it also talked about the challenges and the risk factors for the 21st century pandemics. But yet, the world did not take it seriously, neither our country nor 190, 200 other countries. So for which the globe or the world has paid heavily. Hope at least now, after seeing the consequences of the delay and also not giving enough attention to the preparedness, I hope that from now on we shall take these threats seriously and pull out those plans from cold storage and start acting at least on few of them. The time to prepare for the next public health emergency is probably now, today. Actually, it was yesterday. Although it is very difficult to predict which microorganism will trigger the next pandemic, I'm sure if we are going to have a broader template, the infrastructure ramp up, including testing capacity, the beds, the human resources, and infection preventionist capacity, the channels of communication, etc., etc. If we are going to do all these activities, probably they are going to help us to cushion the impact to some extent, because there are a lot of skeptics who keep saying what preparedness, what vaccine, nothing is working, you guys don't know yet what is the cause, you don't know the etiology, you don't know the treatment patterns, etc., etc. Let us actually not go into or get engaged with those pessimistic kind of people, or the people who wail the time and occupy our minds with unnecessary discussions. I think we should not go into that discussion. Rather, we should be focused on preparing for the next based on the learnings which we have had during this pandemic and also the past pandemics. And one last probably point I will touch upon, and then I will hand it over to Dr. Iyer, is that since we have seen uh, like in any pandemic, a lot of kind of confusion, and nobody knew which role who had to play, and since there was no one single center which was actually dealing with all the issues related to the pandemic, we have lost a lot of valuable time and also a lot of valuable lives. And of course, I'm not going to talk about the economic loss what we have seen. So, and hence, probably it is the time for all of us, who are interested in the public health and shaping actually the public health infrastructure in India in a better way, and also all the infection preventionists. I think we had to make a plea to the government of India that, in line with the National Disaster Management Authority, that is NDMA, probably there had to be a permanent center to better predict, better prepare, and better manage the next wave or the next pandemics or next public health emergencies whenever they are going to emerge. Like soldiers who train a lifetime for one worthwhile war, I think we need to have same continuous preparedness in public health parlance in order to ensure that our populations are going to remain safe, and our world is going to remain safer during the next public health emergencies. With that, I thank once again Sanmed Healthcare, uh, University of Hyderabad, and all the colleagues, who have put in long hours in order to deliver this beautiful program. Thank you very much, and Dr. Iyer, um, over to you, sir.
Thank you. Can everyone
While
hear me? Am I audible?
Yeah, while Dr. Ranganathan Iyer is preparing actually to speak, let me very briefly, of course, although he doesn't need much of introduction, everybody knows him. His stature is so big within the infection control and also the microbiology community. But still, for the sake of formality, let me actually give a little brief. Dr. Iyer currently is a consultant for the global hospitals, and also he is the consultant for Rainbow Hospitals. He had played a very crucial role in organizing several events for Indian Association of Medical Microbiologists, and also he is very active in HISI, that is Hospital Infection Society of India, and several other organizations who are striving to make infection prevention and control a better practice within India. I think with those few words, Dr. Iyer, because if I'm going to talk everything about your activity, it would go very, very long. So, to be brief,
Sure.
I'll hand over back to you.
Yeah. I think there's a small echo. Is it echoing still? No.
No,
Right, fine. Good afternoon, everyone, and thank you so much to the organizers. Thank you so much to IFCAI and the management. A big thanks to all the four panelists who have agreed to be a part of this event, the panel discussion, and try and discuss various aspects of COVID-19 infections and what has happened during as well as after the two waves of the pandemic. While we talk, I would request the audience to follow us up on the panel discussion and also put whatever comments, questions, or clarifications that you seek onto the comments section so that we will be in a position to handle some of those at least at the end of the brief interlude that we will have with the four panelists. I have very distinguished panelists with me this afternoon. We have Dr. GVS Murthy, who has been the director of IIPH in Hyderabad, and he also happens to be a professor at the London School of Hygiene and Tropical Medicine in London, in UK. He has talked to us on the first two waves of the Indian pandemic of COVID and the lessons that we all learned for the future. This will be then we have Dr. R. Sukanya, who is a clinical microbiologist of great repute and who has cleared her IDCC from the Hinduja Hospital in Bombay and also a PGDID from the infectious diseases from the University of New South Wales in Australia. She talked to us on vaccines for COVID-19 and their role in prevention. Then we have Dr. Anup Warrier, a good friend of mine, who is a senior consultant in infectious diseases at the Aster City in Cochin, and he also happens to be a visiting faculty at the Amrita Institute of Medical Sciences in Cochin, which is AIMS Cochin in the field of infectious diseases. And of course, finally, how can I forget our dear good friend from Bombay, who spoke on co-infections and secondary infections in COVID-19, who also happens to be a co-mentee and a co-student of Dr. Geeta Natraj. Both of us have worked under Dr. Geeta Natraj, and we owe it to the GS Medical College and the KEM Hospital, me as a lecturer and she as a postgraduate student. She works at the Breach Candy Hospital as a distinguished consultant clinical microbiologist and also heads the Department of Pathology and Microbiology. Breach Candy Hospital, by the way, is a near and dear place to me because that place was responsible for putting me on some kind of a platform as a consultant microbiologist. I really learned to pick up my threads in the field and get going. And all that I can say is it's only because of the Breach Candy Hospital and the GS Medical College and KEM Hospital that I started really knowing the subject after my MD. Well, after this brief introduction, we will move on to a few facts which we could know from our distinguished speakers. Dr. Murthy, my first question would be to you to open up the discussion on COVID-19. We have had two surges in the pandemic, which people also call as waves of the pandemic. The first wave and the second wave. The first wave happened sometime in 2020. It occupied the greater part of 2020. And the first half of 2021 has completely been occupied by the second wave of the pandemic. Now, what has been your experience? How would you look at the differences between these two waves? And there has been a lot of talk about how did we go wrong? Where did we go wrong? Why did the second wave become more disastrous than the first wave? The first wave was still tolerable. That probably because we were understanding, we were still coming to terms with a lot of things with COVID-19. Whereas in the second wave, we knew a lot of things and still a lot of things went wrong. And epidemiologically, the patient population that was affected, the types of complications that we saw, the mortality and the morbidity rates that came up were slightly different in the second wave as compared to the first wave. What is your opinion, and what's the kind of differences that you saw between the two pandemic waves?
Thank you, Dr. Iyer. Uh, I think one of us will have to mute our mic to reduce the echo. Yeah, fine. So, like I mentioned about a month ago, there are certain differences, and the differences when you talked about the second wave and early 2021, we had a Ganges wave also in between, the water flowing down the Ganga, and a lot of people going there to congregate, which also is perhaps a wave. It's not a sea wave, but it is a river wave, which has actually led to a lot of the dispersion which has occurred from the end of February. So the two major differences, if I were to look at it, is the fact that, like you just mentioned, the first time that we had the outbreak, we also had certain actions taken by the government or by people themselves that actually helped to slow down the curve. So you had a prolonged period between March 2020 to November 2020, a very prolonged, gradual increase and decrease. The wave, as we call it, had a bigger base compared to the second wave. So that, I think, is very critical. And this is because mobility was restricted to a great extent and people were indoors. It was something new and people was apprehensive. By the time we came to November, when most of the restrictions were removed, from the people's minds, the apprehension disappeared. And the scenario, whether it is the elections or the religious congregations or even partying at a local level, that actually started bringing people who were still susceptible together and becoming fertile ground for an outbreak to occur. And this is going to occur not once, not twice, but many times till the people who are susceptible would reduce. So basically what we talk about herd immunity, in many communities, unknowingly it has occurred because a large number have got infected, specifically in the second wave. So what happened now was that in a much shorter period, with a large group of susceptibles congregating together, people got infected very rapidly, and therefore the cases started jumping up. and there was nearly a 90% increase in the case load in the second wave compared to the first wave. In terms of the death rate, unlike popular perception, the second wave, the deaths actually were just about 30% higher than the first wave, but they occurred in a very short span of time, very rapidly, which is why we were able to see a lot of people in front of our eyes. And that was what caused a lot of pain. But if you look at the case fatality rate, there was a tremendous drop between the first wave and the second wave from about 1.4 to about 1, which shows better management of at the medical management level, which is important, and that has made a difference. But also the fact that there's unregulated medicine use, so people had been forced to use medications which were not empirical or which were not evidence based. So all things happened, but the overall death rate in the second wave compared to the first wave was low, was about 30% higher, so the case fatality rate was lower. What is also interesting to keep in mind is the fact that slowly new mutants would occur. And the analogy that I would use is that despite all your burglar alarms in the house, when a thief comes to your door, they will try the conventional method of entering the house. But if you have high tech gear, all the elements, electronic elements put in as a burglar alarm, it may work for a couple of weeks, but the burglar will always get the better. So he would find a window or a ventilator which is not connected and through which he can enter. So the burglar also mutates his technique, and that is what happens when we look at any infectious diseases. So going to the future, like you just asked, we know that there are only two things that will occur, whatever waves also go up, come again in relation to COVID or any other infections. It is either the respiratory route, which is going to be a major concern, or the gastrointestinal tract. So as far as COVID is concerned, we are now better aware of how we can control, having learned from our experience in the past in India, as well as looking at what has happened outside. But remember, it is a thief at your door. Mutations will occur. The virus will find new mechanisms to enter the body, so we have to be prepared to deal with them. That's what I'd say as my opening remarks, Dr. Iyer.
Right. Thank you so much, Dr. Murthy. In keeping with this, what is the kind of scenario that we look at as far as vaccinology is concerned? We have two main vaccines in India, and right now my question is to Dr. Sukanya, who's dealt with vaccinology in great detail. And how would you look at the future in India as far as the
Yes,
availability
Dr.
of
Iyer.
vaccines, potent vaccines to combat this illness is concerned? Do you think it's good enough to continue with Covaxin and Covishield, or do you think the Pfizer vaccine or any of the other vaccines that have hit the market, and there is a new set of DNA vaccines which are still yet to come, and do you think all of those are going to make a big difference to the epidemiology of COVID in the future?
Yeah,
Dr.
thank you,
Sukanya.
Dr. Iyer, for that introduction, and also for thank you, Dr. Iyer, for the question and also for the introduction. Like looking forward in the future, I feel presently also we have a lot of activities in the vaccinology section for COVID, wherein plasmid DNA vaccines are actually being in going to be manufactured in sync. There is a import of vaccines by Cipla, and Zydus is also looking at production of vaccines in India. So there will definitely be the future definitely looks very hopeful with regards to the offering of a larger variety of vaccines, so that whatever vaccines shortage we are right now facing, definitely there will be some sort of a solution which we can achieve for that. So definitely in future we are looking at different types of vaccines which will probably help in enhancing the vaccination coverage, which is now slightly lagging behind because of the supply issues. But there is plasmid DNA which is coming in. There is also Covavax, which is your subunit vaccines, which are also in the pipeline. So there are a lot of vaccines, and I think that will really help in addressing this shortage, as well as awareness regarding the adverse effects as well as myths, which I had discussed in my session, will definitely help in decreasing a lot of vaccine hesitancy associated with the vaccines, COVID-19 vaccines.
My next question is to both Dr. Murthy and to Dr. Sukanya. Now that we've had some stumbling blocks in the vaccination program in India. Children have not been vaccinated. The initial set of vaccines were not available to the 18 to 44 age group. Even now, it's sort of there, but then it's a very slow start. Do we see, is there an apprehension that this could be the major vulnerable group should the Delta Plus variant hit the Indian shores in the near future?
So should I take it first, because you mentioned
Yeah, fine,
first?
fine. Yes, Dr. Murthy, followed by Dr. Sukanya.
Sure.
Yes.
So a very pertinent question. I also happen to be on the WHO task force on school reopening after COVID, and this is a joint commission.
Yes, sir.
This is a joint commission between the WHO, UNICEF, and UNESCO. And what we've looked at is evidence from about 191 countries across the globe. Over the last 1 year, we've been tracking these trends. And unlike what is generally thought, each wave does not lead to an increase change in terms of a younger age population getting infected. What it actually means is that as long as you protected a group of people, once you make them open out, then they are the susceptible group, and therefore you would see more. Having said that, we see that across all these 191 countries, there is very little evidence that infection actually comes from, say, the schools to the community. It generally passes from the community to the schools. So if we are in a high transmission phase, there is likely to be that infection being carried to the schools. So children being disproportionately infected in the future may not be actually correct. What we have seen already is that in those areas in the country where adult seroprevalence is high, children's seroprevalence, despite school closures, despite staying at home, is also nearly as high as 40 to 50%. So they've already got infected. The big advantage is that they have a milder infection. Yes, you have severe manifestation in some children, but many of them have underlying pathology, mainly milder infection, which is why in most countries, the lowest age at which immunization has been given is 12 and above. Even in the UK or the US, US it's not started as yet, but in the UK that is the practice. So we need to look at the realistic situation of children getting infected along with the adults, parallelly with the adults, synergistically with the adults in the household. So to think that they've not got infected as yet is a myth. They've already got infected. And having a vaccine, children would be the last priority group because they are at the lower risk of serious infections. But once the situation improves and vaccines are available, definitely we could include them as part of the UIP. Remember, 140 million doses of the vaccine are required every month if you're looking at just the 18 and above population. So you're
Right.
going to double that in the future.
Right. Thank you so much. Dr. Sukanya, do you have anything to add to this?
No, I'm in sync with Dr. Murthy's statement. In fact, that has made my answer much easier, because we have already seen about the immune responses to natural infections following COVID-19. And if you look at the natural immune response, it's extremely robust as following natural COVID-19 infections. It's extremely good, and in fact the T cell memory as well as the B cell memory cells are in very high numbers, as well as they robust in their immune response, especially in asymptomatic infections. There are several studies which I have talked about in my previous session. So in fact, children, as Dr. Murthy has said, already have actually high seroprevalence of for COVID in COVID. So it generally means that they are already exposed to natural infections, which is very good and which is very robust. Now, giving an additional vaccine, in order to train the immune response, in order to make it more robust, so that you get a very good secondary immune response, is an additional booster or an advantage, which I could say. Yeah. So that I think answers the question.
Right. Thank you. We move on to the therapeutics group. Dr. Anup, my question to you is, right from the beginning of the pandemic, we kept saying, Eureka, hurrah, hurrah, we found something, and then we said, no, this is not good enough. It started with hydroxychloroquine, with ivermectin, with azithromycin, with tetracycline, with plain crocin, all sorts of things. And then there's been a big array of antivirals which physicians have been trying to treat their patients with. What is the kind of difference that you've seen as far as therapeutics is concerned in the first wave and the second surge of the pandemic? Do you feel that we have reached some kind of a stability as far as treating patients is concerned, or do you still feel that we are still groping around in the dark?
So Dr. Iyer, so the first wave, I must confess that from the clinical team there was a lot of panic, and what we traditionally call as throw the kitchen sink approach, where whatever is out there be it in a WhatsApp message or be it,
it was all prevalent all through the world, so no problems there.
Yeah. So we pick up all the drugs which are published, all the drugs which are there in WhatsApp messages, all the drugs which are there in published literature, and try to give to the patient with the hope of saving him. WHO did something very sensible in terms of arranging and correlating large multicentric trials, RCTs, solidarity, recovery, etc. And by the second wave, we had this solid bedrock on which the WHO built up some evidence for good use of therapeutics. So in the first wave, we did not have that benefit. We went by a lot of anecdotal data. And in the second wave, we had this WHO-driven multicentric RCTs. By the early 2021, there are also professional bodies who had sufficient good quality literature to analyze and bring out some therapeutic guidelines, say the NIH or the IDSA, etc. They had enough literature to serve, to generate evidence and to give out guidelines. So definitely there was a significant difference from how we handled it in the first wave and the second wave. Did it make a huge therapeutic difference in terms of outcome for the patient? To some extent, especially in the critically ill, I believe yes, it did make some sort of a difference. But if you ask me what was the greatest difference, it was that we avoided over treatment, we avoided unnecessary treatment compared to the first wave. And we also have evolved in terms of the what you call armamentarium for treatment. So initially, like what you said, there were some drugs which came up with a lot of hype, which were proven to be false, which did not work. So I just made a list of a couple of these which did not. So hydroxychloroquine, as you mentioned, has now good quality data to say it does not work. Ivermectin, even though there are a lot of literature, none of them are good quality studies, and good quality randomized control studies failed to establish its benefit. So ivermectin is also something which is out. Monoclonal antibodies is something which has recently come in the last couple of months. Again, there has been a lot of popularity on this. We should remember
there are far too many of them as well.
Yeah.
There are far too many monoclonal antibodies, and one really doesn't know which is worse than the other.
So for India, it is pretty much simple. Right now, we just have one molecule from the Roche Regeneron available, the Casarimab Imidavir combination. But one word of caution regarding this, we should remember that when we prescribe, we also keep in mind what is called as number needed to treat, meaning how to select the population who would benefit. So if you give monoclonal antibodies to everybody and anybody who comes into the inclusion criteria of the trial, the NNT would be somewhere around 45. So you need to spend, 45 people need to spend about 60,000 rupees if you use this indiscriminately to have benefit for at least one patient. So that we need to keep in mind. Remdesivir, even though WHO did not recommend, a lot of both from clinical experience in among the peers and the IDSA and the other professional bodies still continue to recommend remdesivir in a select population. Favipiravir, very little evidence. It was something which we again used so much in the first wave, not so much in the second wave. Colchicine, recent publications, but NNT is very huge, 70 for again non-hospitalized, not very popular. Steroids have made their stand in terms of
Molnupiravir.
Molnupiravir is a newer antiviral launched by Merck. The phase 3 trials are yet to be published after peer review, so we are waiting whether that makes a difference. So it is again for the mildly ill and pre-hospitalized patients. So again, I am very skeptical whether it will make a huge change in the therapy. We know that majority of them get well without medicines. So if you place a drug in that 80% more likely to get better without drugs, I am very skeptical whether it will make a difference in the overall outcomes. Among the immunomodulatory drugs, tocilizumab had a lot of hype in the first wave. It slowly died down in the second wave. Our use of tocilizumab was much more targeted, focused. Instead of placing it late in an extremely sick patient, we selected the group which would go into ventilation, and the use was limited or reduced in quantity. Baricitinib made its appearance in the second wave instead of tocilizumab as an adjunct to remdesivir, but the data is not that huge for that, but that is something which has come up. And the last phase, that is, now we are dealing with a group who have sequelae of severe COVID, and antifibrotic like nintedanib and pirfenidone has made their place in this late sequelae. And obviously Hyderabad is a place where in India they have done 45-50 lung transplants for COVID. So that sort of finishes the whole spectrum of asymptomatic, mildly symptomatic to lung transplantation for the people with sequelae.
Right. Before I leave you, I have another question which is going to lead me to Aruna later on. In the second wave, we did find people scurrying around for oxygen cylinders. There was a huge amount of steroids being used, right from 40 milligrams to 2 grams in some patients. And this was coupled along with monoclonal antibodies in various doses. And still you had a lot of patients dying. You had a small subset of patients surviving, but getting readmitted once again with holes in their lung, with cavities in their lung, with secondary bacterial infections, with secondary filamentous fungus infections, and so on. What is your opinion on what actually should have been done? I mean, has the physician group settled down with how much of steroids ought to be used in a particular patient and what ought not to be done?
Yeah. Okay. So what not to be done is the easiest thing for me to say, because if you look at,
but then finally, what you should be doing is more important, isn't it? After all this experience.
So it is easy to sort of comment that we should not use steroids in the early viremic phase and in patients who are not even on oxygen supplementation, because all the data, all the publications, guidelines, etc., focus on this group, people who want to develop oxygen supplementation and then up to ventilation, where the use of steroids were found to be beneficial. In the ventilated group, the number needed to treat was 8 for Dexona in the Requital. So that means extremely useful. So we should not use that in somebody who is not even requiring oxygen in the early viremic phase. It's proven to prolong the viremia, increase viral replication, transmission, etc. So this is something which from the clinical team and the prescribing physicians that we to hold on and not use steroid in the early group. So there the dosing is not a concern, just do not use. So when you come to this group where yes, steroids are indicated, that means they are on oxygen or they are on ventilator, and now how much steroids should you use? So here it is unfortunate that we still do not have a major consensus within the clinical groups, even though the recovery trial has dosages of 6 to 8 milligram of dexamethasone a day. There are multiple clinical trials published, which the range which you mentioned, so starting from hydrocortisone of 56th hourly to methylprednisolone in pulse dose, that is 1 milligram a day, and the ARDS protocol of high dose methylprednisolone for consecutively for 5 days. So even though we have a consensus on where not to use steroids, where we use steroids, we still do not have a consensus on the dose nor on the duration, because it still continues to be very patient specific in terms of response to hypoxia, progression to fibrosis, where especially the pulmonary team would tend to lower the dose but give a long duration, especially when they settle into this fibrosis or late sequelae phase.
Thank you. Let's move on to Dr. Aruna Poojary. Aruna, you've been an infection consultant, a consultant microbiologist dealing with a lot of infections and infection control. We did see during the middle and the later part of the second wave of the pandemic a big scare of black, white, and yellow filamentous fungi. This came up almost every day in every newspaper that I could read or lay my hands on, and there was a big scare in the community. Do you really feel that we had such a huge outbreak of filamentous fungal infections, or was it geographically restricted to some parts of India, and it did unnecessarily create a scare in the other parts of India? And did it override the bacterial infections that we saw in equal measure? I can tell you that I saw more bacterial infections than fungal infections here in Hyderabad at Global.
So I think, meaning I agree with you, media has played a very important role, and WhatsApp universities have played a very, very important role all through COVID, whether it was the first wave or the second wave. And as you rightly said, we were getting all colors of fungi
Yes.
being, put
With
out.
no identification. That's the worst part of it.
Every other day, black, white, red, everything came in. And so because of this media hype, I think the community awareness to some extent came in, but at the same time, it also led to panic. And I must also agree with you that I saw at least 3 times more bacterial infections
Exactly.
versus the fungal infections. And that was typically in the critical cohort, where mortality also was very much high.
Very high.
I guess the fungal infections that really created panic, mainly mucormycosis, not even aspergillus or even the candida, which was actually causing deaths in the ICU. It was more attention was focused on mucormycosis.
Mucormycosis, yes.
And that was all, media hype. There could have been areas where, for example, here in Mumbai also, most of the tertiary care institutes, we never really faced a major outbreak of mucor within our own institutions. Most of our cases have come from referred centers in the periphery, from smaller cities, which probably did not use the steroids well. They were all patients who probably had mild disease, didn't even require steroids, had no hypoxia, and were treated with steroids. And that was the reason, meaning this was not a universal phenomenon, but unfortunately, because of the media, there was a big hype, and the real focus, the ones that actually caused mortality, were left behind.
Right. And there are two things that I would like to say. We had our share of aspergilli, but many of them were colonizers of the lung. That's because we found them more often in patients who came in with pulmonary cavities. And quite a few of these also turned out to be acid fast positive, which means the immunosuppression that was afforded by the steroids coupled with the monoclonal antibodies probably flared up a latent tuberculosis. And along with the TB, there were these cavities, which were the hidden seating arrangements for aspergillus. And of course, a couple of patients did have invasive pulmonary aspergillosis, as evidenced by a galactomannan assay positivity. We did also see some mucormycosis, but then I think it was hyped out of proportion. And Yoron's presentation, I was just going through your presentation before this session, and I did find that in your session you've said that out of about 9 patients of invasive candidiasis, you had about 7 of them dying of invasive candidiasis with various species, be it Candida albicans, tropicalis, all of that, Saccharomyces and things like that. So it's something that one needs to be very careful. How do you think an infection specialist and a microbiology consultant should be prepared in the near future if we at all start seeing another huge outbreak? I mean, another wave. Let's put it as wave. I mean, everybody likes to call it wave, though actually it should be called a surge of the pandemic. So, if we at all have a third huge surge of the pandemic, which brings in more disaster than what we have already seen and experienced, how do you think we should be prepared as infection consultants?
So I think, meaning I would like to focus. There's an echo.
Yeah.
So I would like to focus, most of my time and resources on the cohort which is likely to, meaning die, where mortality would set in. So it's naturally the critical cohort where I would like to focus most of my energies on. Too many devices, very ill patients, use of immunomodulators, use of steroids. These are the kind of patients where I would prefer to, enhance infection control,
Hmm.
ensure that our people who are with PP are doing hello are doing good hand hygiene, are adhering to all the hand hygiene practices which we've seen has reduced, because meaning people don't recognize that wearing gloves you still need to do hand hygiene. So that's been a major compromise. So ensuring that hand hygiene is done just as we did or better than we did in the pre-COVID times in these areas, doing a good environmental cleaning and disinfection, something very important, taking care of all the devices. Aseptic handling of the devices is very important again in these areas. Ensuring that your respiratory equipment, all your other invasive equipment are taken care of. We've used ECMO. That can also be an important reason why infections can set in. So I think I would like to really focus my energy from the point of view of infection control in this category of individuals where mortality would be the highest. Next, probably the mild people where we really don't need to do anything. There's no reason to cause panic. Let them be as they are. No need to do any intervention, and let them, get over the infectious duration. That's all.
Right. We also have been seeing a small share of non-tuberculous mycobacteria. We've just about started seeing that. And we really don't know, because many times you don't land up doing tuberculosis cultures, so it's very difficult. You see them on smear, but the gene expert is negative. So obviously you know that you could be dealing with a case of non-tuberculous mycobacteria. The other thing is, what I wanted to ask you is, nocardia is something that comes up as a pathogen when your cell-mediated immune defense mechanisms go down. Now, if we do see tuberculosis, if we do see fungal infections and some amount of bacterial infections, how is it that, why do you think nocardia is something that has spared us till now? Otherwise, you can have very bad pulmonary infections with nocardiosis.
So, meaning I've fortunately or unfortunately not seen nocardia, but I
Same
have
here.
heard from colleagues in Mumbai who have seen nocardia.
We've
So
seen nocardia.
I think we might be missing them. I
Exactly.
think
I just
as
wanted to say that.
microbiologists, we need to do everything for that sample that comes in. Meaning I understand that there are cost issues and things like that, but I don't believe that in that critical cohort we should go every length to try and identify the
Exactly.
pathogen, whatever
Just
it
throw a
is.
very wide net so that you can catch as much fish as possible, as many
Absolutely.
varieties of fish as possible. Right. Okay. So now there are a couple of questions from the audience before we move on. I think we are at 15 minutes up, almost 15 minutes up. And I think before we run out of time, there is a question from Dr. Satish Kumar, who says that despite taking your 2 doses of Covishield and Covaxin and all that, a lot of people have still not developed antibodies. Why is this? Do we need to worry about these set of people? what is the proportion of people? Has there been any study like this? Do you think they need to take a booster, or will they benefit because they took a couple of doses of booster, or the entire vaccination once again, or change over to a Moderna or a Pfizer or a Sputnik vaccine from Covishield and Covaxin? Can we request Dr. Sukanya to answer this, please? Or maybe even followed by Dr. Anup Warrier. Yeah, Sukanya. Dr. Sukanya.
Yes, sir.
Yeah.
Yeah. So,
You
yes,
got the
yes.
question,
Can
right? Yes, I can hear you. Go on.
Yeah. Now, the thing is, whenever we talk about detection of antibodies post-vaccination, we are relying on commercial tests which are available in the market, only going to detect total antibodies to COVID-19. Now, whenever we talk about immune response post-vaccination, we are looking at not only neutralizing antibodies, we are also looking at T cell responses. So when you talk about the immune response following vaccination, it is a repertoire of neutralizing antibodies, B cell responses, memory B cells, as well as T cell responses. So these three, parameters, the immune response, are actually not detected by any commercial kit which is available right now. What we're detecting in the laboratory in the form of the available commercial kits are all detecting only total antibodies. They do not detect specific neutralizing antibodies. We cannot say that antibodies against the spike protein are all neutralizing. Only a percentage of the spike proteins which would be neutralized. So we do not have a definite, we cannot really say that there is a definite immune correlate for post-vaccination, right? So in such a scenario, definitely we have seen from the laboratory that when we do antibody testing post-vaccination, many times we get it as negative. That means it is below the detectable level. Now, when you look at the immune response following the vaccination, even if you look at the antibody response, there is a peak of antibody, and then there is a downfall, a decline, and then you have a plateauing. Now, how soon the peak occurs, okay, for how long it remains at a detectable level differs from person to person depending upon their immune response, right? And as I already told in the session, there is not too much of a difference between IgM and IgG. The onset of IgM and IgG. We really can't say IgM is early and IgG is late in COVID-19 because sometimes we see both of them appearing in and around the same time. So in such a scenario, I would say that please do not rely on antibody testing, which is available as a evidence for immune response following vaccination. Okay, it has been proven. We only have to look at clinical.
Sorry. Yeah, what about a specific antibody to the spike protein?
Exactly, sir. Even specific antibodies to spike protein.
Yes.
Yeah, even specific, spike protein antibodies or even antibodies which are actually targeting the RBD, the receptor binding domain, they are doesn't mean that they're neutralizing antibodies. Now, some of the laboratories are doing neutralizing antibody tests also.
Yes.
But again, there's a big study, Australian study, which actually looked at neutralizing antibody titers as immune correlates. But because there is no standardization of the kits which are used for neutralizing antibodies, so even if you do neutralizing antibody test, using cell lines, we do not know what is the cutoff of neutralization titers because the kits are different across different, the test kits are different. So there's no standardized titer cutoff for neutralization, and therefore there's no single neutralization titer which we can arrive at. Neutralizing antibodies, though done, there is no specific titer which we can arrive at in the laboratory.
Yes.
And there is no method of also detecting CD4 and T cell memory because those are extremely very difficult by flow cyto, and that's not really possible right now. So I believe the only advice at this stage is do not depend on antibody testing. Please go ahead with both 2 doses of vaccines or whatever vaccine schedule is there as per your vaccine, the type of vaccine. Exactly, along with the other, preventive measures like social distancing, hand hygiene, etc.
What's your take on this, Anup? How would you respond to this?
Couple
So
of things.
this
So this is a
question from
question.
Satish Kumar.
Yeah, so this is something which we very often get, especially from healthcare workers, from our colleagues and peers who are working. So there are, if I would take back one thing from what Dr. Sukanya said, is that it is quite complex, right? Whatever it is, it's a very complex situation.
Yes, it
So
is.
I tell them two, three things. One is that whether you have responded to the vaccination depends on your genetics, the state of health at that time, based on comorbidity, drugs, etc., and various other factors like the administration thing. So, being vaccinated is no guarantee of being immune. We know that. So, as for an individual, it is of no guarantee that you can either be without mask or go into crowds, etc. So that part is done. You are not going to look at immunity to what you call dilute your precautions. So that is first. Second thing I tell them that unfortunately we do not have any reliable test by which we can rapidly and simply measure whether you have responded, whether you are immune or you are not immune. And that is the gist of what Dr. Suganya was also mentioning. We do not have a simple, straightforward commercial lab-based test which can tell whether the vaccine has worked for you or it does not have worked for you. The third thing which I just wanted to add on to this is that globally, in many countries and in a lot of data, looking at or pointing towards need for boosters, because this was also a part of the question. So, in my perspective, if at all we go on for a booster for the gentleman who did not respond to the initial or a category, if with whatever measurements, antibody titers or whatever was done, with a booster, I would probably go with a vaccine of a different type. So that is the only sort of thing, even though I don't have much data to say so. I know that there are trials looking at mixing of different categories of vaccine. So based on some of the stuff which is coming up, maybe if I go for a booster, I might go for a booster with a different kind of vaccine. That's all I want to add.
All right. There is another question from Dr. Deptt Mane. This is also on antibody levels. What could be the reason for antibody levels to decrease over a period of time? Why does the antibody levels decrease over a period of time? I think it's known in many viral infections that the antibody levels do decrease. Yeah, but then anyway, to answer the question. Yeah, any of you? Anup?
Yeah, so not just for any infection, that is the as I understand it, it's a natural process, right? Once you have an antibody response, then naturally it comes out. It's a natural response. That is how the immunity functions. So we have memory B cells and T cells, which after some time, when you have a reinfection or a re-exposure, that kicks in. So we do not expect whatever antibody response we got during primary infection to remain at that level lifelong. We expect it to wane off. We hope that our memory B cells and T cells will kick in when we have a re-exposure. So my answer to that is this is the natural functioning of immunity for any disease.
Right. A question to you as well as to Dr. Aruna. Do both of you all feel that the use of voriconazole does act as a risk factor for zygomycosis?
Well, the idea is primarily that you are trying to reduce the pressure on aspergillus, and hence this is mostly it was true with the BMT population. We know that we consider if somebody has on voriconazole prophylaxis and they develop fungal pneumonias, we say that okay, he's on voriconazole, so aspergillus is unlikely. So probably this fungal infection is due
On
to
to the other ones which are not covered by Warrior. Okay.
Correct.
Yeah. Any other opinion on this, Dr. Aruna Poojary?
So I think same, meaning it is the pressure of antifungal agents probably which might be playing here.
Yes. Yes.
And just one comment on the previous question. Actually, I agree with both the speakers who have said, I can't remember a disease which we might have tracked with performing so much of antibody testing. I think there lies the problem. Where we know, meaning we know that it's normal, meaning immunology, where we expect our IgM, to go away after some time and IgG to go away after some time, but we never track them. In COVID, I think we've done excessively tracking of everything, and as a result of which we panic over how long the immune response can be measured and seen.
Right. Before I leave, I think we just have less than a minute. Before I leave all of you all, what would be a good vaccine for cancer patients? This is from Dr. Mamta Srivastav. What, in your opinion, would be an ideal or a good vaccine to give to a patient with cancer? Quickly, please, 30 seconds.
Yeah, so
Which COVID vaccine is good for cancer patients? Anybody? Come on, come on, come on.
Yeah, Dr. So from my perspective, if you look at immunogenicity and of the group of
Okay.
vaccines available, we had the mRNA vaccines with the highest immunogenicity. So if you ask for that, even with an mRNA vaccine, there are trials for oncology population which showed just 50% efficacy. So of the lot, I have a choice, I will go for mRNA vaccine.
Right, right. Mr. Pranav, can you just pass it on for a minute more and we will end the whole thing? Pranav ji?
Yeah, we can continue. No issue. We can
No
continue.
issue?
Sir. No issue.
Okay, all right. If that is so, I just wanted to ask one single question on this antibody level business. If I can see all of them, yeah, that's fine. Now, when we had the first surge of the pandemic, I'm not going to say use the word wave. I mean, when we saw the first surge of the pandemic, initially there was some talk about using convalescent plasma to treating patients. And then there were proponents and opponents of this thought. I do know of the fact that neutralizing antibodies was something that the West talked about in convalescent plasma donors. You need to establish neutralizing antibodies to a particular titer before you could consider them as significant, as good enough to give convalescent plasma for patients with mild to moderate COVID. Now, this was dashed down by the ICMR study that we had and which was later published. And it clearly said that convalescent plasma is absolutely useless. Now, for one, I don't believe that any one single modality is absolutely useless. It is not. I mean, if you can use hydroxychloroquine and ivermectin and all of that, you can also use convalescent plasma. We have also seen patients with mild to moderate disease not progressing to the severe illness when they were given convalescent plasma along with your remdesivir, along with a very low dose of steroids and things like that. What does the entire panel feel about this? Do you still feel convalescent plasma is useless? And therefore the use came down in the second surge of the pandemic? Or this is one question. The second question is, the first question is about the utility of the convalescent plasma. The second question is, if you could gauge or judge the utility of convalescent plasma based on neutralizing antibodies, we do have a GenScript assay kit which talks about more than 30% neutralizing antibody percentage in terms of percentage. Do you think such a kit, such a test principle could throw some light on antibody levels and the efficacy of vaccination in our population? Yeah, so anybody, Aruna first, followed by Dr. Sukanya, and then maybe Dr. Murthy and Dr. Anup Warrier. All of you all can have a quick response to this.
So I think
And
the crux of everything that we've dealt with in COVID and the many therapeutics that we have looked at is selecting your patient appropriately. So whether it is your immunomodulators like tocilizumab, if you use it in the wrong patient, naturally it would be a disaster. And the same thing probably happened with convalescent plasma as well. I have been using GenScript since probably Jan to estimate neutralizing antibodies. And what I have seen is that during the second surge, as you mentioned, we did have patients, we had a lot of breakthrough infections in healthcare workers itself. So I think if it were the original strain of the virus, it's a good assay to determine the neutralizing antibodies. And it would be useful to measure, whether this particular donor can be is suitable for convalescent plasma donation.
Yes.
I mean, it could be used, certainly. I think it's a good assay.
Dr. Sukanya? Dr. Sukanya? Oh, are you with us, Dr. Sukanya? Okay, Dr. Anup, before we get on to her. Anup,
Yeah,
can you respond to this?
Yeah, so the three things, efficacy, safety, and logistics. So if I look at efficacy, I agree with you with when we have a proof of neutralizing antibodies, and as Dr. Aruna Poojary was mentioning, in the right patient, it could give us that efficacy which we want. So that is one. Safety, It is it's just like blood transfusions and plasma extraction, etc.
I
So if
agree.
I have monoclonal antibodies which spare me from this part, I would, from the safety part, I would not consider. Okay, efficacy probably the same. Safety, monoclonal antibody would be safer in terms of the blood and body fluid pathogen and the transfusion related risk. Third is the logistics, which includes collection of plasma and the cost. So cost, obviously, plasma is cheaper than monoclonal antibody, but the collection logistics has its difficulties. So if you are able to have good donors, then it is a cheap alternative to monoclonal antibodies. So that's my
Exactly.
take.
I, for one, definitely felt that the pharma company group really shot down convalescent plasma as being absolutely useless. But then I stand corrected on this. Anyway, Dr. Sukanya, are you there with us? Would you respond to this question? No, I think she's frozen in time. I don't know. Okay, Dr. Murthy.
Yeah,
Let's.
so
Yes, Dr. Murthy.
just to
Yeah.
clarify what you just mentioned, it is important that we set a best practice in whatever we follow. So it's
Exactly.
not just about something being useless or something being very useful, but something which has at least some amount of evidence to back its utilization. If you do not do that, it just becomes grandmother's medicine or anecdotal practice. So there has to be some evidence,
Yes.
whatever be the quality, it may be not be the best, but whatever be the quality, that should guide the utilization. And if you look at that, not only has the Indian government, but even the WHO has not recommended. It
Not
has
recommended.
not dissuaded, but it has not recommended.
Hmm.
So, keeping all the evidence that is available, if you have local evidence that it works, I don't think there is any loss in using it, as long as, like what Dr. Warrier mentioned, the safety perspective is absolutely meticulously adhered.
Right. Dr. Sukanya, are you with us? Is it possible to get a quick word from you? Dr. Sukanya, we're waiting for you. Hello? Yeah, Dr. Sukanya, yes, I can see you moving. Yes.
Aruna.
Yeah, yeah,
Yes, can you
go
hear
on.
me?
We're waiting for you. Yes, 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 we can hear you. Come on.
Hello?
Yes, yes, we can hear you. Come on.
Can you hear?
Go on. Hello.
Yes,
Yes.
so it will be being summed up very well by Dr. Anup and Dr. Aruna.
Okay.
The plasma therapy, as you had put it in the right perspective, definitely has its advantages, and in terms of cost, obviously, is better than monoclonal antibodies. And regarding neutralization assays, I think it is the way forward as to establish a criteria of a screening which plasma is really going to be useful in which cohort of patients. That's it.
Right. Okay. If that question is answered, uh,
Hello.
I would. I mean, if there are, I don't see any further questions from the audience.
Can you?
If there aren't any further questions, yes, somebody is asked what would be a good vaccine for a patient who underwent CABG. Anybody? CABG, post CABG. What vaccine would you consider?
Yes, so Dr. I do not think there are any specific considerations.
Exactly, that's what I thought. But then I still felt that the experts on the panel should be answering this. All right. So then, if there aren't any further questions, I thank all the panelists for having taken out their precious time from their schedules as we wade through the end of the second wave. Hopefully, the end of the second wave and no more waves. But then that's wishful thinking. I'm sure we need to be very well prepared for a couple of more surges of the COVID pandemic before we can call it a day with COVID-19. And we definitely need to enhance our testing ability. We need to enhance the diagnostic capability of laboratory medicine, which actually plays a very, very important role, not just in diagnosis, but even in patient management. And we definitely need to up the kind of therapeutic protocols. We definitely need to have some kind of a protocol worked out for how to manage which category of patients, which actually is a huge challenge. It's not very easy to do so in today's world. But then, having said that, this is the best that we could hope for, apart from wishing that all our entire Indian population gets vaccinated by the end of 2021, so that we are, I mean, all of us would have developed immunity to some extent in our efforts to combat the SARS-CoV-2 illness in the near future. Thank you so much. Thank you to IIPH management and to everyone in the panel, as well as to everyone in the audience who has been, who've been very patient listening to us and who have taken out time again from their busy schedules to be with us in this particular panel discussion webinar. Thank you so much, everyone, for your kind indulgence. Over to Mr. Pranav.
Thank you very much, sir. Thanks for, and I would like to thank here the sponsors, Sunmed also. They have supported the entire series of 5 webinar. Thanks a lot. And this recording will be available there in youtube.com Sunmed Healthcare for all the 5 sessions. Thanks to all the panelists, and a special thanks to moderator. The way you have conducted, I think, very nicely knitted all the points, all the speakers' input. Thank you very much, sir. All the participants can respond to the quiz. You can see here the ipcmasterclass.live/quiz.4. Your certificate will be starting going from tomorrow onwards. Thanks. This we are ending the session now.
Thank you so much.
Thank you. Thank you.
Thank you.